Our next speaker is Dr. Julianne Holt-Lunstad, Professor of Psychology and Neuroscience at Brigham Young University. Her research has been seminal in the recognition of loneliness and social isolation as risk factors for early mortality, and we're so fortunate to have her with us today to share her work.
Thank you so much. And that was a fantastic presentation to follow. I am going to put a bit of a spotlight on the problem. And so what I hope to really cover is first defining what we mean by some of the terms that we use, because oftentimes terms are used very loosely, so I think it's important to define these. Also, what are the estimates of the size of the problem and the seriousness of the problem, as well as some risk factors and potential solutions. So one of the things I think it's important to first distinguish is that loneliness and social isolation are often used interchangeably, but they don't mean the same thing. So social isolation is thought to be much more objective. It's actually being alone or having few relationships or infrequent social contact. Whereas loneliness is thought to be more of a subjective experience of feeling alone, or the discrepancy between one's desired level of connection and one's actual level of connection. And so it's important to recognize that someone can be isolated but not feel lonely, so they might actually enjoy their solitude, and conversely, someone can feel lonely but not isolated. So, for instance, people often report feeling lonely even in large groups or at parties or other kinds of social settings. They may still feel lonely. So it's important to distinguish that these are different, but of course they can go together, but not always. So in terms of really defining what exactly is the issue or what is the problem, there are often a lot of other terms used as well. And so it's really important to recognize, is it the actual perception of loneliness that's the issue? Is it lacking social contact or interaction? Maybe it's lacking a close, intimate partner or someone in the home to rely upon in times of need. Maybe it's having strained relationships. But I hope you can see that even by this incomplete list that there are a variety of ways in which this might be an issue, and that having a lack of clear definition may be a potential barrier to really addressing the problem. So in looking to the research and the way in which it has been studied, we can see that it has been measured in also a variety of ways that can generally be categorized under three general headings. And so the first really gets at, it is referred to as structural aspects of social connections. So this gets at the existence of social ties and roles, and might include things like size of social network, social integration, marital status, living alone, in essence, the presence or absence of others in our lives. But of course, we also know that functional aspects of relationships are important as well. So some research has looked at the kinds of resources that are available or perceived to be available via social relationships, and then others have also looked at the positive and negative qualities of relationships, because we need to acknowledge that not all relationships are entirely positive, and so some have looked at relationship satisfaction, conflict, and ambivalence. So as a means of trying to, and I should mention that each of these measurement approaches have been significantly associated with health outcomes. And yet there are relatively low correlations between them, suggesting that they may be all having an influence on health, but perhaps through potentially different mechanisms. So to try to address the issue around definition and defining the problem, my colleagues and I have proposed using the term social connection as an umbrella term that would encompass the structural, functional, and quality aspects of relationships that all influence physical health, and that we can consider this on a continuum such that high social connection or high social connection would be associated with low risk or protection, whereas low social connection would be associated with high risk. So in other words, we can think of terms such as social isolation and loneliness as being indicators of low social connection, but other kinds of indicators such as structural and quality, such as living alone and poor quality relationships, would also be forms of low social connection. But we also need to acknowledge that the high end may be protective. So we define the problem as low social connection or social disconnection. So in terms of what is the prevalence rates around this, or to what extent is the population affected by this, we first need to acknowledge that many indicators are not routinely collected. And so getting precise estimates may be difficult. The one source of data that is routinely collected is U.S. Census data, which really gets more at some of these structural aspects. So, for instance, more than a quarter of the population lives alone. Over half of the U.S. Population is unmarried. 1 in 5 have never married, and the divorce rate in the U.S. is around 40% of first marriages. Of course, caution should be used in assuming that just because someone lives alone or is unmarried that they may be socially disconnected, because they may very well have a very large social network. So this is a imperfect and crude measure. Nonetheless, both living alone and marital status are not only risk factors for loneliness, but they are independent risk factors for premature mortality. When we look to other kinds of indicators of social disconnection, we can look to surveys. For instance, the recent Cigna report suggests that nearly half of Americans report sometimes or always feeling alone. Now, it's important to recognize that there are a variety of different surveys out. Another estimate found this closer to 22%. And because of measurement differences, these estimates may vary. But nonetheless, even a more conservative estimate of 22% still suggests that a significant portion of the population is affected. We also, as acknowledged earlier, need to recognize that there may be economic costs associated with this. And so, for instance, the AARP study that found $6.7 billion in additional Medicare spending each year And of course, this was just focused on older adults and focused on Medicare spending, and doesn't take into account other ages or other sources of costs that may be much larger. So in terms of establishing the evidence around the seriousness of the problem or the magnitude of the problem, my colleagues and I have conducted a couple of meta-analyses, which is a way of combining the available data worldwide to determine the magnitude of the risk for early mortality. And in my first meta-analysis, we looked at, this included data from 148 studies and over 300,000 participants. And what this data showed was that social connection was associated with a 50% reduction in risk for early mortality. And that was, of course, adjusting for age and initial health status that could rule out reverse causality. And so and my second meta-analysis looked specifically at indicators of objective and subjective isolation. And so what we found, let me go back to that. Unfortunately, it doesn't look like the information is, maybe I can do that. There we go. We found that this meta-analysis included data from over 3.4 million participants. And what we found was that the risk for loneliness, social isolation, and living alone each significantly predicted risk for premature mortality and did so equivalently. So I think that's rather remarkable that both objective and subjective isolation are important and equivalently predict risk. And this was consistent across gender, initial health status, cause of death, and country of origin. So to really benchmark this against other kinds of risk factors that we take quite seriously for our health, the orange bars on here represent a variety of indicators of social connection. The blue bars indicate a variety of leading health indicators, the top being smoking up to 15 cigarettes per day. And what we can see is that although there is variation in how strongly these different social indicators predict risk, as do some of these other leading health indicators, the blue bars on the bottom that all of them are either equivalent to or have a stronger effect include physical activity, obesity, and air pollution, factors that can receive considerable attention and considerable resources. We also have good data that this affects other indicators of health and well-being. As mentioned earlier, the risk for heart disease and stroke. It's also associated with a 64% increased risk of developing Alzheimer's disease. Wounds heal slower, and it's associated with greater perceived stress and depression, so other kinds of emotional and mental well-being, as well as poorer sleep that in turn is also linked to mental and physical health outcomes. There are a number of risk factors that have been identified, and I'll just highlight a few. So, for instance, poor health and well-being, including things such as mobility impairments, cognitive impairments, and poor mental health, can increase your risk for being socially disconnected. life transitions, role loss and change, including leaving the workforce, loss of partner, family, or friends, societal barriers, lack of access and inequality, and communication barriers. All of these have been linked as potential risk factors for social disconnection and loneliness in particular. So the top line includes some demographic factors that, and as well as social factors that can also put you at increased risk specifically for loneliness. So we need to recognize that there are multiple causes, and because there's no single causal factor, no one approach will work for everyone. So for those that, if the underlying impetus or cause was mobility issues versus someone who had a loss of a spouse, the approach might be very different for one compared to the other. But we also need to recognize that many other current public health issues also have multiple underlying causes, and therefore this should not be a limiting factor in addressing this issue. So one of the key questions is what do we do about it? What works? What doesn't? And while there is evidence of the interventions that have been effective, there are also some notable exceptions to this, and so we need to acknowledge that the evidence is somewhat mixed around this. And so we do need to pay careful attention to our approaches in addressing this. One thing to note is that of all of the different measurement approaches in terms of predicting, one of the least robust of these and is received support. And we need to acknowledge that just because someone receives support, it may not always be perceived as supportive and may not be helpful if it isn't responsive to what is needed or desired. And so we do need to acknowledge the potential for this in our approaches that could limit our potential success. So to borrow from public health, we need to also consider a social ecological model. The majority of interventions that exist currently are very focused on the individual level, but according to this model, we're missing many opportunities to intervene at interpersonal, organizational, community, and societal levels, and that we really also need to consider interventions that go beyond just tertiary level interventions that are aimed at those that are highest risk or when the problem is severe, but rather also consider primary and secondary level interventions where we target this at a preventative level early on to prevent this. And then finally, just the way in which this can occur typically goes through three general approaches. And so even at each of these levels, we can consider whether the approaches are aimed at supporting and maintaining existing relationships, building new relationships, or are psychological approaches that are aimed to change thinking about relationships. And with that, I will turn it over to Robin, who can describe some of the efforts that they are doing at CareMore. Thank you.